So basically, the task of the presentation is to provide some evidence on tobacco harm reduction strategies. And it is, of course, an important topic. And first of all, I would like to remember everybody that foremost Italian cardiologist Attilio Maseri has died recently, and I think is an orthodox approach to research and clinical practice, trying to challenge dogmas, is something that we should bear in mind when tackling smoking, which is an old disease. It's not a COVID, but it's still very challenging. This is my disclosure. So basically, it's challenging to summarize what has been published or presented or collected on tobacco harm reduction, because the literature is growing exponentially in the last few years. The key point is that people are becoming aware that this is something viable that can impact patients and healthcare systems substantially. So we know from the prior presentation, we all know that the smoking epidemic is there to stay unless we do something proactively and use a multidimensional approach, which can reduce the burden of this disease worldwide, but also in your family, in your institution, among your friends, and so forth. We are well aware that many support strategies are available and effective, that pharmacotherapy can be useful. It's not game-changing, but the good thing is that these drugs may have some adverse effects, but they are suitable for prescription and reimbursement to patients. So the main change in recent years from snus to electronic cigarettes is the concept of modified risk product. So a modified risk product is a tobacco or tobacco-like product which can modify, hopefully reduce, the global burden of disease associated with smoking. Note, this is very important, that the modified risk product claim is a complex one, multidimensional. It's not the same thing as saying a reduced risk product claim. So the key point is that some products may have a modified, hopefully reduce risk, but this has to be shown, and actually we will have to be aware and cautious for many years, possibly decades. However, it's important to be pragmatic and optimistic in a way, and so we can define typical MRPs such as vaping cigarettes, Blue, Juul, many others, and heat-not-burn cigarettes such as Glo, IQOS, and many others on the market. So what is the dilemma? Should we proactively promote modified risk products to rescue smokers using combustion cigarettes? Or should we ban, limit, avoid supporting MRPs in order to save the vapers? So where is the balance? What is more effective and useful and ethical for society, for individuals? Of course, there are several pros and cons. For instance, behavioral psychotherapy, replacement therapy, and this kind of thing may have some safety, some efficacy. Safety can be reappraised over time, but the key problem with the smokers is the appeal. So it's very difficult to motivate a smoker to give up combustion cigarettes unless we offer an alternative. Also, we don't need to see each of these interventions as a one shot. So you're trying to hit a target and you have only one bullet. In my practice, I've seen people shifting from one MRP to another one, to a softer one, and then eventually cessate, go to abstinence altogether. So we need to see this as a path rather than as an alternative where you are stuck once you have made your decision. And indeed, there is a harm continuum as well, from combustion cigarettes to chewing tobacco, snus, and possibly lower risk MRPs. We have done a lot of research on this. We have tried to capitalize on our experience, to be frank, as former smokers, and the usefulness we recognized in MRPs. We have done several studies on this. We have ongoing studies, a study done in patients with coronary artery disease. We are planning 2 multi-center trials of mentoring of electronic vaping cigarettes and heat-not-burn cigarettes in primary prevention. And after that, hopefully, we will apply for funding for a pragmatic randomized trial in secondary prevention. We have also tried to summarize all the evidence on the safety of MRPs and particularly cardiovascular safety. And we found that indeed we have signals of adverse effects. So MRPs are not necessarily safe, not at all. They have a small but measurable risk. Most of the risk is due to actually nicotine, which is the active agent we are delivering together with all the gestures and the style of the smoker. Indeed, the nicotine has been associated with the acute myocardial infarction, hypertension, tachycardia, oxidative stress, and so forth. Indeed, we're trying to recommend to be flexible and consider MRPs as allies which can support the patient toward cessation and abstinence. And you may think that some people may go on cessating altogether from smoking. Some people will need some counseling, some drug, some replacement therapy. Others will need a vaping cigarette, other stage heat-not-burn cigarettes, and then a vaping cigarette, and so forth. We don't need to be rigid. However, if we want to be more rigid, we have now randomized trials showing that electronic cigarettes do reduce smoking and are associated with a substantial increase in cessation. This is a meta-analysis of randomized trials published just a few weeks ago. However, no trial included heat-not-burn cigarettes. Also, the Cochrane collaboration just released their meta-analysis on e-cigarettes for smoking cessation. And in this case, we have a comparison versus nicotine replacement therapy, and we have a significant benefit. However, take into account that the study quality is not always excellent. So the internal validity of the trials sometimes is suboptimal. We may also try to summarize the complex alternatives. So nicotine-free control, nicotine replacement therapy, e-cigarettes, and this is what is called the network meta-analysis. And we can indeed see that electronic cigarettes with nicotine are associated with substantial cessation success, as well as nicotine replacement therapy, but electronic cigarettes are superior also to nicotine replacement therapy. If you are interested in statistics, we may discuss this later. There is some suggestion that there could be some bias, some selective reporting favoring some type of interventions. So the jury, in a way, is still out, and we need larger and longer follow-up trials to settle this definitively. But it's clear that cessation rates are increased by using MRPs. Moreover, very recent data suggests that MRPs may also be cost-effective. So on top of being effective, likely reasonably safe and efficacy substantial, they can be a good investment for society. Remember, though, that MRPs are devices to deliver nicotine. Nicotine is not safe. So every nicotine uptake from a patient is going to be a minor hit to his safety, to his health, to his well-being. And this is very clear. Indeed, we could envision in the future a transition from a nicotine-rich MRP to a nicotine-poor MRP. Of course, device companies are not very interested in nicotine-free products because they are less addictive, and so they are less suitable to create long-time customers. And this is a major struggle that we need to be aware of now, and especially in the future. What are the MRP effects? Summarizing them, the pros are the reduction in traditional combustion cigarette use, increase in total cessation from tobacco combustion cigarettes, improvements in respiratory symptoms, exercise tolerance, quality of life, and rate of disease exacerbations. Of course, there are cons. We promote nicotine addiction. We may have adverse oxidative and vascular effects, again, mostly due to nicotine, but there might be other agents which are detrimental. And there is also a risk of tampering, especially with custom solutions. We may have lung injury or also the abuse of illicit drugs. The key point, we have uncertainties. There is no data on long-term, 10, 20 years safety, overall pulmonary, cardiac, and moreover, oncologic, which will require time to test and exclude. Why, if you are a skeptic, should you avoid MRP? Because the cigarette is not vapor. They may have a unique and unknown harm profile, distinct but still substantial in comparison to combustible cigarettes. They may have a threefold increase in serious adverse events compared with the drugs. They can be abused extensively by adolescents, teenagers, and they create nicotine addictive. However, we can think MRPs as tool, as dangerous but useful weapons to be leveraged. First of all, it's true that most of the harm caused by combustion by tobacco is caused by combustion. So if we avoid combustion, we get rid of the worst enemy. Nicotine, though not benign, is not directly responsible for most of the cancer, lung disease, and heart disease. Although it is not possible to precisely quantify the long-term heart and the other damage of e-cigarettes, available data suggests that they are unlikely to exceed the extent of those associated with the smoked tobacco products. Indeed, it's true that the harm reduction approach is psychologically completely different and thus more appealing for smokers than a smoking cessation mantra. Indeed, this is quoted verbatim. Basically, e-cigarettes, MRPs, are alternate source of nicotine without combustion. They are suitable to achieve significant reductions in risk of cancer, cardiovascular, and respiratory disease. And the recommendation of this author from CHEST is that healthcare professionals should be positive and open-minded towards their use. My conclusions instead are simply that smoking represents the most impactful yet actionable risk factor of cardiopulmonary disease and cancer. E-cigarettes and heated tobacco cigarettes are MRPs which may improve cessation and abstinence rates from combustion cigarettes, but may create new smokers or impede eventual total cessation from nicotine addiction. MRPs may have substantial cardiovascular effects, and again, I do recommend their use only when envisioning smoking cessation in patients at low risk and also setting a specific time for eventual discontinuation. Many thanks for your attention.